Greetings. This is Dr. Jim Drzegescu, your CHC Medical Director. We are pleased to provide and continue to grow our CHC Educational Library, which was created to educate CHC members about initiatives and best practices for improving the consistency in delivery of care following clinical practice guidelines. These topics were selected based on their overall value for improving our patients' health. Clinical integration relies on our collaboration with each other in order to have the greatest impact for our patients that we collectively serve. We hope you find the presentations in this educational library useful. We value your membership and expertise. If you have any suggestions for topics to add to this library, please let us know. I hope you enjoy the following presentation.
Hello, my name is Leonard Spishikoff. I'm board certified in addiction medicine, and we will be talking about how to prescribe opiates in patients that are naive, although certainly we'll try to expand a little bit on patients that are experienced, as they also have their own unique problems. We will attempt to define what is an opiate naive patient. Also, we will talk about what steps can you take as a provider to help our patients that are going to be started on narcotics, and also what are the warning signs of misusing a prescription. Now, some key statistics, and these are obtained from the National Survey on Drug Use and Health, which is NASA, and this is actually a survey that is done through the NIH and SAMHSA. And what it does it on a yearly basis, and you're able to determine who or where prevalence and incidence of disease may be. For example, an estimated 21 million people aged 12 or older needed substance abuse treatment. And this is defined as needing substance use treatment if they had a substance use in the past year, or if they had received substance use treatment at a specialty facility in the past year. So as you can see, the number is large, and this does not account for those that don't come into treatment, which is triple or quadruple this. Now, there's also 28.6 million people aged 12 or older who have used an illicit drug in the 30 past days, which corresponds to about 1 every 10 Americans. Now, interestingly, when you look at this data, there's also other data that shows that in the adolescent population, just to kind of compare it to alcohol, 1 in 4 adolescents has used alcohol. So this tells you how prevalent this is. Another number that's interesting is there's an estimated 11.8 million people who have misused opiates in the past year, including 11.5 million pain medication misusers and close to 1 million heroin users. The main reason they have used these is they have used it to relieve physical pain. Although the most common place people obtain their narcotics is going to be from a friend or a relative. And subsequently, these were initially prescribed by a physician, so we must always be aware of whom we're prescribing these to. Now, let's do a little bit of terminology. We'll talk about what is chronic pain. Chronic pain is any pain that extends beyond 6 months. Now, the definition of acute and subacute will be self-explanatory. Now, we also have chronic non-malignant pain, and it's pretty much its definition what it is. Now, we have misuse, which is the use of a prescription for a reason or a dose not originally intended. There's also tolerance, which means that we have to increase the medication to achieve the desired effect. Many medications, you do develop tolerance. Dependence means that there is a state of adaptation manifested by a syndrome with withdrawal being present once you have stopped the medication or you have dropped it too fast. Now, keep in mind that you can have tolerance and dependence and not necessarily have addiction. There's other characteristics that need to be present. Now, lastly, we want to talk about pseudo-addiction. And these are patients that have all the characteristics of what seems to be an addictive behavior. The main thing is that once the pain is properly treated, the behavior tends to subside. But many times this is pretty difficult to discern, and it takes time in getting to know your patient to be able to ascertain this. The overdose prevention states in this slide tells us where these programs are present. So as you could tell, the state of Illinois, Wisconsin, Indiana has a program. Interestingly, they also have it in Kentucky and Tennessee and West Virginia and Ohio, which have some of the highest numbers of opiate overdose deaths. Hence the use of overdose prevention. In this case, monitoring medications or the prescription or Narcan, particularly in patients that are using more than 50 morphine mil equivalents per day. That's where it should be used. Our next slide is overdose concerns, and as you could see, it's a very confusing slide initially, but once you start looking at the data, you could tell that some of the highest incidences of and prevalences of overdose concerns tend to be confined to the East Coast, also around the Ohio Valley states, in Indiana, particularly in southern Indiana, where they also had an outbreak of HIV because of substance use disorders. So this slide tells you where it may be concentrated, although certainly no part of the United States is going to be immune to this. Now, what is the main problem? The problem is there's too many prescriptions, number one. Number two, there are less and less prescriptions for non-narcotic medications, including the use of acetaminophen, ibuprofen, naproxen, the use of physical therapy, exercise, cognitive behavioral therapy, or even referral for psychotherapy can be very helpful without having to use narcotics. Now, the other problem that we exhibit is that patients receive medications for long periods of time. There's actually studies that have shown that patients who have overdosed in the past many times will get the same prescriptions once they get discharged from the hospital, or they'll get reinitiated by their originating physician or some other physician. Interestingly, the other studies have shown that 3 days or less is often enough, or more than 7 days is rarely going to be needed if you're treating acute pain. And keep in mind that also we must consider the condition that we're treating. In this slide, if you look at this, there is a mention of 50 morphine mil equivalents per day. That increases the risk. Now keep in mind, if you look at the slide, there's another data that shows 90 morphine mil equivalents per day. These are indicators of possible overdose, and the use of prescription of Narcan is highly recommended. Now, the way we come to this is there is a formula that can be looked up. For example, hydrocodone has a value of 1 morphine mil equivalents per day. If you're giving someone 10 milligrams / 325 per day, that would come up to about 40 mil equivalents per day. Now, if you go a little higher, that's going to be over 50. Hence, you would have to use Narcan to avoid overdose or death. Now, what is also recommended is that we use the lowest amount of immediate release opiates. And one thing we must talk about, when you're treating pain, always use immediate release opiates initially. In special situations, you may have to use extended release. If there's doubt, call. There'll be always some guidance as to help you with this. Now, risk factors for abuse and overdose include obtaining overlapping prescriptions, multiple providers and pharmacies. Having a substance use disorder or a mental health illness is another huge indicator of abuse and overdose. Taking high dosages of prescription and opiate pain relievers, living in rural areas, or having low income. But we also must consider people that are higher risk or people that are younger, not unemployed, and all these factors have to be considered. To give you an estimate of how grand the problem has become, around 46 people die every day from prescription overdose. So this is something we must be concerned about. A question that you could use, just do it in a non-confrontational manner, would be, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? Pretty simple, open-ended, and many times it will help you. Another questionnaire you could use is something called a CAGE-AID, which is basically the CAGE questionnaire, which is also added drugs. The CAGE, as you know, is used for screening for alcohol, and then the AID is used for screening for drug abuse. If this is positive, then you can move on to using something called a drug abuse screening test, other tools, or you can refer them for further evaluation, period. Now, who should be screened? Those who have a personal history of physical, emotional, sexual abuse, those with a personal family history of anxiety or depression, history of substance abuse disorder, once again, if they live in a dysfunctional, chaotic living environment, if they've had legal problems, or anybody who's going to be in chronic opiate therapy. One thing that I must also caution, there are studies that have shown that there's an increased amount of depression in people who are on chronic opiate therapy, and this has to do with depletion of serotonin and other neurotransmitters in the brain secondary to being on chronic opiate therapy. Now, another thing that we have to look at is we need to look at the prescriptions being used, illegal substances, the use of alcohol and tobacco. The use of alcohol and tobacco by itself is a marker of possible substance abuse, so we always must inquire. A family history of substance abuse and psychiatric disorder is very important, as 50% of substance use disorders can be genetically predetermined, so knowing your family history can be of help. Another thing that is important is a history of sexual abuse, employment, cultural background, social networking, marital history, legal history, and other behavioral patterns, as all of these can preclude a substance use disorder and hence need to be looked into. Another tool that we can use is very simple. You could print it out and give it to your patients. It's something called the Opioid Risk Tool Assessment. And it talks about the criteria that we have mentioned as far as who's at risk for developing a substance use disorder. Now, one thing we must talk about is the highest age group for the risk for chronic opiate dependence is going to be between the age of 16 and 45. So this is something that must be always asked or looked into. Once again, some of the risk factors: age less than 45, being male, being prescribed opiates for more than 3 months, anybody who's been prescribed more than 120 milligrams based on morphine equivalents. If you have seen a patient obtain prescriptions from multiple prescribers, history of legal problems, mental illness, or personal family history of substance use disorder are factors to be considered. Now, how do opiates affect the brain? Well, prescription narcotics and heroin, they affect the reaction through a neurotransmitter called a G-coupled protein. And so what occurs is most opiates tend to go to the mu receptor, which subsequently causes the G-coupled protein to send signals to the nucleus accumbens and the ventral tegmental area, which increases your dopamine, and further relay to the prefrontal cortex. And this little circle is called a reward pathway, and that hence causes a trigger and reaction that furthers a person into substance abuse, particularly if they're predisposed. Now, there are neurochemicals that we need to be aware of, particularly when we're prescribing opiates. And one of the ones that is the main neurotransmitter for substance use is going to be dopamine. Dopamine is not only causing euphoria, but it also will perpetuate the liking of a drug because of its reward. And as you can see in this slide, you see dopamine causing euphoria, also analgesia, relaxation. It also increases serotonin, and hence they feel elevated mood, they feel happy. And it works on your GABA receptors as well, so it decreases your anxiety, they have less panic and relaxation. To the contrary, when a person is not on opiates, what will they feel? They'll feel tired, dysphoric, they'll have sadness because of serotonin, increased pain because of the opiates, increased anxiety and panic attacks because of GABA. They'll have increased hyperexcitability from glutamate no longer being suppressed by GABA, and henceforth. Now, what to look for as far as for the stages of opiate withdrawal? It depends on the half-life of the opiate being used. And also, we must caution, it depends on how long you've been using it. Now, on average, most people will have symptoms of withdrawal at 48 hours. Depending on what the person is using, if it's a short-acting opiate, they tend to have them sooner. If it's a longer-acting opiate, they tend to have them further out. On average, most people will have symptoms of drug craving, anxiety, yawning, rhinorrhea, coryza, sweating, cramps, muscle twitching, diarrhea, and these will be symptoms that you can easily characterize by using a clinical opioid withdrawal scale. Let's talk about who and how we're going to prescribe. The prescription that it's liked by patients, especially if they have substance use disorder, must have a high street value. It must have rapidity onset and must have a recognized trade name. Hence, you may have a patient that comes in and says, oh, I only want Norco, I only want oxycodone. And they can actually tell you the amount of milligrams they've used and what's been effective for them. These are people you may have to look into very carefully. Also, take in consideration if they have a history of substance use, if they're young, if they've used controlled substances in the past for non-indicated reasons. These are things that need to be looked into. Now, there are studies that have looked at what physicians can do, and they have found that sometimes when a physician is hurried, he may not have the capacity to screen, or he may not be up to date on some of the recommendations, or he's easily deceived by the patients, or yet that they may just not have time to concentrate on what the patient is trying to convey or screen correctly. In any event, one must always go in with open eyes and open mind to be able to understand the patient and do the right thing. When to consider opiate therapy. Potential benefits, when potential benefits are likely to outweigh risks, if they have not responded to non-opiate drug interventions which we previously mentioned, the pain is moderate to severe, always try immediate release opiates. And if this fails, then one may advance to other forms of therapy. And more importantly, also consider the analgesic and functional goals of treatment. If these are not being met, and this can be inquired by inquiring about the IADLs and such as to the quality of life. I want to also remind everybody that the prescription of naloxone is highly recommended nowadays. An important thing might be to consider rotating opiates. Calculate the medications that you're prescribing in morphine male equivalent dosage, and there's formulas that are readily available on the web. On long-acting opiates, particularly in conjunction with short-acting opiates, be aware that you need to calculate the morphine male equivalents. Be careful not to prescribe over a 30-day supply, and be careful with those who are over 65, as these are people that can easily overdose. Be careful if a household has children or someone who may not be able to understand the label of the prescription. Also be aware of patients that you are treating if they're homeless, they have lack of transportation, no phone service, if they recently have been incarcerated, if they have a history of drug abuse and they've not used medications that could be habit forming, they are at increased risk for overdose and possible death. Be aware of concurrent prescriptions, in particular benzodiazepines, antipsychotics, antiepileptics, muscle relaxers, in particular carisoprodol, which goes by the trade name of Soma, hypnotics, and antihistamines, as these all increase the effect of narcotics, and also the effect of CYP450 conjugation in the liver, and hence can affect the way that medications are distributed for the body. So always consider prescribing naloxone. The takeaways that we wish to convey is try to use non-pharmacologic therapy. Non-opiate pharmacologic therapy is going to be the most important. Discuss the risks and benefits with the patients. Select immediate release medications initially. If not functioning, then you may consider extended release or long-acting opiates. Always look at the amount that is being prescribed and morphine equivalents, how long you're going to be prescribing it. Have a plan on how to taper the medication. Other data that need to be considered is what are the possible harms? How can I mitigate patient risk? Review the prescription monitoring program on a regular basis. Do random urine drug testing. Try to avoid the prescription of benzodiazepines. And if the patient shows evidence of substance use disorders or there is concern, arrange for referral so they can be evaluated for opioid use disorder. Here at Palos and our behavioral health program and chemical dependency treatment program, there is the ability to provide inpatient treatment, partial hospitalization program, intensive outpatient treatment. There's recovery groups and aftercare groups, and there's also the ability to offer medication-assisted therapy, and so patients can be evaluated from the onset and even after they've been discharged and for the longer term of treatment. Most patients that do have chemical dependency or opioid use disorder, alcohol use disorder, or other disorders benefit from initial treatment and aftercare, and more importantly, the involvement is going to be from a team effort, not only from physicians, but other providers and family, which is very important in the treatment of these patients. Thank you.